I'm Justin Robinson, an integrated CT resident at the University of Maryland and current Kirkland Ashburn Congenital Research Fellow at the Cleveland Clinic. Under the mentorship of Dr. David Sabata, a cardiac surgeon at the University of Maryland, I will be discussing blood component use in cardiac surgery, specifically FFP, platelets, cryofibrinogen concentrate, factor 7A, PCC, decision criteria, and other options. The objectives will be to discuss basic mechanism of action and also to highlight indications, adverse effects, and contraindications. However, I won't be going into depth into those. The decision to use blood tests and diagnostic tools and discuss current practice guidelines. Fresh frozen plasma, or FFP, contains all coagulation factors except platelets, and it functions to correct coagulopathy by replacing or supplying these plasma proteins. Some indications include abnormal coagulation and active bleeding and reversal of warfarin and active bleeding. Cryoprecipitate contains factor 8, von Willebrand factor, factor 13, fibrinogen, and fibronectin, and this provides hemostasis to treat or prevent bleeding. Fibrinogen, it supports platelet aggregation and can be used in massive trauma, liver disease, and cardiac surgery. Recombinant factor 7A, it activates factor 10, which subsequently leads to conversion of prothrombin to thrombin, resulting in a blood clot. Prothrombin complex concentrate, or PCC, contains several factors such as factor 2, factor 9, factor 10, and variable amounts of factor 7, and replenishes coagulation factors. The decisions to use oftentimes can be decided on by blood tests. However, the big advantage of using any of these blood tests are the time that it takes to obtain the results. And they do not provide a complete picture of hemostasis due to their inability to assess some coagulation factors and the activity of the fibrinolytic system. Thus, there are other diagnostic tools that can be used, such as thromboelastography, or TEG, and rotational thromboelastometry, or ROTEM. The benefits include a global assessment of blood coagulopathy, platelet function, and fibrinolysis, and these are rapid real-time tests, and they can guide transfusion therapy and decrease the use of blood products. Here's an illustration of a TEG, and the parameters include an R value, which is the time until initiation of fibrin clot formation, the K value, which represents thrombin-platelet interaction, the alpha angle, which is the rate at which fibrin cross-linking occurs, the maximum amplitude, or MA, which is the maximum strength of a clot. The Lie30 is the degradation of the clot 30 minutes after MA. So if a patient has a prolonged R time, this will indicate a quantitative or qualitative deficiency in coagulation factors and can be corrected with FFP, PCC, or anticoagulant reversal. A prolonged K time or decreased alpha angle may suggest fibrinogen deficiency, and this can be corrected with cryo or fibrinogen concentrate. A low MA reflects quantitative or functional platelet deficiency and can be corrected with platelet transfusion or desmopressin. Increased Lie indicates active fibrinolysis and can be treated with TXA or aminocaproic acid. And the opposite will be true in a prothrombotic state in terms of the mentioned changes. This is an illustration of a ROTEM, and it's pretty similar to a TEG. However, the nomenclature is different. The clotting time, or CT instead of R, the clot formation time, CFT instead of K, the maximum clot firmness, MCF instead of MA, and the CLI30 is the lysis index at 30 minutes instead of the Lie30, and the CLI60 is the lysis index at 60 minutes after clotting, and then ML is the maximum clot lysis. Here are a few guidelines for use of these products, and wanted to highlight a couple of them. Plasma transfusion is reasonable in patients with serious bleeding in the context of multiple or single coagulation factor deficiency when safer fractionated products aren't available. And use of recombinant factor 7A may be considered for intractable non-surgical bleeding that is unresponsive to the routine hemostatic therapy after cardiac procedure using CPB. And there are other guidelines here that can be incorporated into the management strategy, such as using DDAVP. Thank you.